Good afternoon, everyone, and thank you for joining us for this webinar on use of administrative records to analyze drug abuse and enforcement. My name is Karen Moline, and I'm with the Justice Research and Statistics Association. Our moderator today is Alan Wedd, a research specialist with the Ohio Statistical Analysis Center. Alan has a BA in psychology from the College of Worcester and an MS in cognitive neuroscience from Michigan State University. As a research specialist, he has examined index crime in major Ohio cities, drug task force performance, opiate-related deaths, and the relationship between casinos and economic crime. Some of his current work involves criminal justice program sustainability, domestic violence fatalities, police community relations, and longitudinal analyses of drugs and property crime. He also analyzes law enforcement data using the Ohio Incident-Based Reporting System. Alan has used a variety of techniques in his research, including crime mapping, data visualization, and data forecasting. Alan, I want to thank you so much for moderating today. Take it away.
Thanks, Karen, and good afternoon, everyone. Like Karen said, my name is Alan Wedd, and I'm a research specialist for the Ohio Statistical Analysis Center. We're located at the Department of Public Safety in the Office of Criminal Justice Services. And it's my pleasure today to welcome you to this webinar on the use of administrative records to analyze drug abuse and enforcement, which is part of JRSA's series of webinars on using administrative records for criminal justice research. If you want to catch up on any of JRSA's past webinars, you can find them on the JRSA website under the Resources tab. These webinars are hosted by JRSA throughout the year to promote the sharing of information by and among the state statistical analysis centers and other justice-related agencies. Before we go any further, I just want to thank our partners at the Bureau of Justice Statistics for making this series of webinars possible. I also need to cover a few logistical items really quickly. So we'll be recording today's session for future playback. The link to the recording will be posted on the JRSA website. Today's webinar is being audiocast via the speakers on your computer and via teleconference. To access the audio stream via your computer speakers, you just have to select Communicate and then Audio Stream. Once the audio broadcast window appears, press play, which is the arrow button, to start the audio stream. If you do not have speakers or if you'd rather use your phone, please use the number contained in your registration email. It's also located on the Event tab located on the top left-hand side of the screen. There are many people joining us today, so we have automatically muted the lines of participants to reduce background noise. If you're not one of the presenters, please keep your phone muted. If you typed in *6 to unmute your phone, please retype it in now to go ahead and remute your phone. If you have questions for the presenters, we encourage you to submit them using the chat feature on the right side of your screen. Please select Host and Presenter from the drop-down menu next to the text box and go ahead and send your question there. If you'd like to communicate with JRSA staff during the webinar, you can submit a comment using the chat feature to Jason Trask, Karen Moline, or Host. This session is scheduled for 1 hour and 30 minutes. We're going to end promptly at 3:30 p.m. Eastern Standard Time. Not going to be keeping anybody late. If you have technical difficulties or you get disconnected during the session, you can go ahead and reconnect using the same link that you used to join the session initially. You can also give WebEx a call. Their technical support number is 1-866-569-3239. That's 866-569-3239. And in the last 5 minutes of today's webinar, we're going to ask everybody to go ahead and complete a short survey. The information you provide will help us plan and improve future webinars and meet our reporting requirements. So now that I've got all that administrative stuff out of the way, I'd like to go ahead and introduce today's presenters. Stefanie Lopez-Howard is the SAC Director and Planning and Evaluation Program Coordinator for the Georgia Criminal Justice Coordinating Council. She became the SAC Director in 2012, and before that, she served as the Coordinating Council, she served the Coordinating Council, which she joined in 2010 as a Planning and Policy Development Specialist in the Grants and Policy Division. There she managed the day-to-day activities for the agency's 200-plus subgrantees of federal crime victims grants. Since taking on the role of SAC Director, Ms. Lopez-Howard has worked on numerous research projects to support the Grants and Policy Division's grant-making and strategic planning processes. These include things like a statewide victim needs assessment, an evaluation of the Georgia International Law Enforcement Exchange Training Program, analysis and amendment of CJCC's Victim Services Outcome Performance Measures, and data reports for external stakeholders. She also writes policy research pieces, and most recently, she completed a needs assessment to determine the volume of and gaps in services for human trafficking victims. The resulting publication was covered in articles about human trafficking by the Atlanta Journal-Constitution and several other local papers. Ms. Lopez-Howard has a Master of Public Administration and Graduate Certificate in Survey Research from the University of Connecticut. Her undergraduate degree is in English Literature from Trinity College in Hartford, Connecticut. Our other presenter is going to be Samuel Gonzales. He's an analyst at the Criminal Justice Coordinating Council. There he's responsible for policy research to support the Victim Services Division of CJCC. He also works with a collaborative in Clayton County, Georgia, to evaluate an initiative to provide prevention, education, and interventions for youth at risk of commercial sexual exploitation. Before joining Georgia's STAC in December of 2014, Mr. Gonzales worked as an organizer with community and labor organizations that dealt with both neighborhood and workplace policy issues. Some of his campaigns focused on ending crime associated with blighted neighborhoods in West Atlanta, ending gun violence in the South Side of Chicago, and identifying and addressing safety concerns at correctional facilities in Kentucky, Kansas, and Georgia. Mr. Gonzales has an M.A. in economics from the Andrew Young School of Policy Studies at Georgia State University with concentrations in program evaluation and labor economics. He has a strong background in econometric evaluation for the social sciences, data management, and public policy. And now I'd like to go ahead and turn the webinar over to Stefanie Lopez-Howard. Stefanie?
Hi, everyone. Thank you, Ellen, for that fantastic introduction. You made us sound a whole lot cooler than we probably really are. So I just kind of want to give, before I turn it over to Sam, I want to give you all a brief introduction to the project in which this whole webinar falls, and that's our state drug enforcement and use strategy/needs assessment. We got funded for it with the 2013 Bureau of Justice Statistics grant, and we're now at the tail end of it trying to wrap up the final report. And we used a bunch of administrative data sets and some non-administrative data sets like UCR and stuff like that, and our own data collections from multi-jurisdictional drug task forces and some data out of HIDA to try to piece together what is the state of both drug enforcement, drug use, and drug treatment in Georgia, to try to come up with some sort of comprehensive strategy that attacks it from multiple points. You know, our sense of it, having now been in this process for about 2 years, is that it's fairly disjointed the way that law enforcement approaches this issue, prosecution, the courts, and even treatment providers. Nobody is really looking at the issue from a both demand and supply side perspective. Everybody's kind of working in their own niche, and our goal is really to try to bring the players together and look at the data, see what is in fact happening, what are our upcoming challenges and hurdles, particularly with respect to drug use and abuse, and how is it that we are tackling that. So we have been looking at a bunch of different secondary data. We've also done some original data collection in service of that. What we wanted to accomplish today with the webinar is really to give people, I think, practical skills and some techniques for the way that we were looking at the data and the way that we were thinking about it, going from raw, sometimes pretty dirty data sets to something that we used for analysis, and how is it that we went about doing that. So if you are super pro at SPSS or data analysis or data mining, and this is really basic, we hope that maybe we give you some ideas for looking at data sets differently and some inputs on, or insights on using syntax and different syntaxes that we've used. And if you are fairly new to data analysis and this is all kind of cool beans to you, well, you're at the right place. And anything that you all need, if you are interested, if you work with test data or you want to work with test data, I think my understanding of it is that it is a fairly standardized data set at the national level, and so I think if you got the data out of your state agency, it might be fairly similar to the data we have, so you might even be able to use some of the same syntax. Anyway, our syntax files are up for grabs, or our analysis techniques are up for grabs. You can reach out to Sam. Sam's better than I, because he's the one that actually has done most of this work. But I'm going to turn it over to him, and we hope that you find it useful.
Great, thanks, Stephanie. Yeah, so administrative data is a great way to get a sense of what's going on in your area. And again, this drug strategy project that we've been working on is a good example of that. We looked at a number of different data sets to try to get an understanding of the drug problem in the state, and felt like we've had some pretty good success with that. We just did a presentation recently with the prescription drugs only, and it was received really well, and we used about 5 or 6 different data sets to make that presentation. But for today, we're going to kind of hone it down to 3 specific data sets that we looked at. Oh, well, first let's go over the goals. And the goal is to introduce participants to you guys to the 3 administrative data sets used for the Georgia statewide drug enforcement strategy. We want to highlight the challenges in our analysis and technical solutions that we use to overcome those challenges. Provide some insight on the need for data surveillance, long-term, or addressing these long-term needs of drug abuse and use. And then hopefully spark a good conversation on how to tackle this administrative data. I think one of the best ways to learn is to have conversations with folks that do this on a day-to-day basis. And we all know that there's many ways to analyze this data, and little tricks and techniques from other people are always very helpful. So those are the goals. The data sets we like to look at today are from the Georgia Department of Corrections administrative data. We focused on intake data only, and that was collected from 2009 to 2013. We looked at drug overdose deaths data, and that data was collected from the medical examiner's offices at the Georgia Bureau of Investigation and Cobb, DeKalb, Fulton, Gwinnett counties, and that was from 2010 to 2013. It's important to note with this data set, like Stefanie said, that a lot of these data sets are kind of dirty or whatever, and we had to combine a lot of data sets together to make this one from all the different medical examiner's offices. But our final data set does not include the county coroner offices, and if folks don't know, there's 159 counties here in Georgia, and it only includes those that's referred to the medical examiner's office. And then the data, and M.P.A kind of talked about this this morning, about how it's hard to identify what drugs cause death, and that's because this data from medical examiner's offices don't include toxicity level. And so if multiple drugs are identified, which is about 84% of the overdose deaths that we found in the medical examiner, or from the medical examiner's office, you know, we can't attribute that to one single drug. So that's one of the problems with it. The third data set we look at is a treatment episode data set, and that's collected by the Georgia Department of Behavioral Health and Developmental Disabilities, DBHDD, for the Substance Abuse and Mental Health Services Administration, or SAMHSA. And basically that data is only for criminal justice initiated treatment episodes. When it came to the Department of Corrections data, we wanted to be able to do a specific crosstab, and if you look, there's a variable called major offense by crime type. It's kind of the middle of that screenshot there. And basically, there's 2 values that it could be. It could be drug sales or drugs possession. And that just doesn't really give us the level of detail we wanted for this analysis. So we just kept on digging around in the data set, and we were able to find these primary offenses variables. And here it's right next to the variable I just listed, and primary offense, and then it went up to tertiary. But we looked primarily at the primary offense. And when you start looking in it, I was like, whoa, there's some good information here. You got a little bit more detailed offense. It's not just drug sales or drug possession, and you actually have the drugs, and that's kind of what our goal was for this analysis. So I was like, man, we really need to clean this up. So we took on the project of cleaning this data up, and so that we could do that, the crosstab between the drug offense and drug. it's a fairly simple fix, but sometimes people can get stuck on this and wonder what to do. And so we thought it was worthwhile bringing it up here today. And basically, this is one of those things that can be solved through Excel. And the way that we tackled this issue was we filtered that column and to see if there was any common phrases, and it turned out that there was. You know, there's possession, possession with intent to distribute, trafficking, were all kind of common in that in the column or in those cells in the column. And then to clean that up more, I searched to remove unwanted words like the word of. There's a lot of those in there because there's a lot of different strings in that cell. Then after that, we searched the common phrases and then replaced them with a comma. And as you can see in the find and replace screen there from the screenshot, I just entered the phrase and then replaced it with the same phrase and just added the comma. And the purpose for that was so that we could do text to columns. And when you remove all those unwanted words, kind of separate out those key phrases that define the major offense and separate the drugs, that created two different variables for us. We were able to get the drug and the primary offense, and we were finally able to do our crosstab on it. And it did provide us with some pretty good information. Recently, we did a phone call with the Office of National Drug Control Policy on methamphetamine, and one of the issues that came up, or people were presenting a lot of different data, and the question was, is there still meth being manufactured in your area? Well, we don't work in law enforcement, so we're not busting the meth labs every day or going out and here it's in North Georgia, and breaking those things down and arresting these folks. But we were able to look at this corrections data, administrative data, and see that there was a primary offense of manufacturing methamphetamine, and we had over 600 people incarcerated during this time period. And so this is a pretty recent time period. This is after the regulations on the Sudafed and stuff like that. So so we still have that manufacturing here. And because we are Atlanta and there's pretty easy access from Mexico to here, and then from here down the East Coast and up the East Coast, we do see some trafficking as well. So it's a good tool to get us an idea of whether there is the manufacture of methamphetamine and the trafficking of methamphetamine, because in some areas the trafficking of methamphetamine from Mexico comes in, it's a lot cheaper than manufacturing it there. It's kind of overtaking that part of the market, but that's just not what we're seeing from this corrections data here in Georgia. So found that particularly useful. The second data set I would like to look at today is the overdose deaths data. As you can see from the screenshot here, basically what these medical examiners do is conduct a toxicology report, and all the drugs that they test for come back, and they put them in that report. And when we requested the data, all the different drugs did come in their own column. There was 12 different, or up to 12 different drugs found in individuals that had overdosed in Georgia. So we had 12 different columns listing these drugs. Problem is, there's no kind of order to them, there's no toxicity level, stuff like that, and we really wanted to get an idea of what drugs are used in combination. Because when you look at this, this is actually us running a multi-response set, and we're hearing this in the field, is that alprazolam is in a lot of overdose deaths, but we keep hearing that they're used in combination with opiates. And so to do this combination analysis, you know, I don't know if, how much experience people have with multiple response sets, but when you first look at it, and multiple response sets is basically all those different, I'll just go back here, all these different variables, drug A, drug B, drug C, being analyzed basically as one variable. But you got 12 of them here, so it's kind of hard to think about how are we going to combine these drugs and do an analysis of drug combination overdose deaths. And we know alprazolam is in a lot of these deaths, but how are they connected? You know, is what we really wanted to see. So the first thing we did is, in this multiple response analysis, all the drug variables were listed as their drug name. You see they're kind of complicated names. A lot of these we've never heard before. But to do a multiple response set or multiple response analysis, these drugs' names need to be in numeric form. So they have to be assigned a numeric value. And so the first thing I did was sort all the drugs. I did it alphabetically, got rid of any duplicates, and assigned it a number. And it ended up being a number between 1 and 183. There's a total of 183 different drugs found in individuals in overdose deaths during this period. So it's a lot of different drugs. But we got to format it for SPSS. And up in the formula bar there, I don't know if you can see, or you should be able to see, is kind of how to combine two cells in Excel, or two cells that have a writing in it in Excel. And in the parentheses here, kind of combine everything, and this is how you, it's kind of hard to explain, but how you combine these two cells. So the parentheses before the and, then you got C2 and parentheses is what designates the cell. So I actually was able to record this in a macro, so every time I want to format a cell, I can just hit one key and it formats the cell for SPSS for myself. And the same goes with labeling it. It's just a little bit different format, but if you use this formula technique and the screen capture, it will automatically combine the two cells in Excel, and then you can just cut and paste and put into SPSS. And for those that haven't used SPSS a lot, here's the syntax for recoding a variable. And so this has the formatting from the Excel slide that I showed earlier, and it's basically the drug name in single parentheses. Yeah, and then hold on, and then it equals that assigned number, and then you just put that. Sorry. So you put that in parentheses. The drug name is actually in single quotes, and then it equals 1 and it's surrounded by parentheses. And then you have the recode, the variable name, the formatting, and then you do into the new drug or the new variable that you'd like to use, or you can actually put the recode into the same variable, and then you label the variable and, of course, the execute command. And then the labeling the variable syntax is very similar. You use the label value labels command. You list the variable. You copy and paste, or what I did was copy and paste my formatting in Excel, put it in there, and then just hit execute. And I was able to recode all the different drug name variables, all 12 of them, into numeric values so we could do the multiple response set. The key for doing the combination drug, and it was really funny in our office, we were having a lot of different conversations on how to figure out how to do this combination analysis. And regression was thrown out there and all these different things, but really it just came down to selecting the data with one drug as the base. It was time consuming, but it got the job done. And so the syntax that we have here is to select alprazolam as the base, and then when you run a frequency, it will run all the drugs that are used most commonly with alprazolam. All right, and so basically it filters out, and because you have 12 different variables that have drug names in there, you have to use the OR and AND commands in the syntax for selecting the data, and you can see it with the compute command, and then you have drug A recode equals 10, which is the value assigned to alprazolam, or drug B recode equals 10, and it goes through drug L, which is our 12th variable or 12th column, and then we also had to get rid of all the other cases that weren't where multiple drugs weren't found in their system. And that was able to give us a base data set where alprazolam was listed as one of the drugs for every individual in that data. And then we ran frequencies to find the drugs that were used most common. What resulted is this nice little chart. And so this is the drug with three most used combinations. And so basically, sticking with alprazolam as our example, it's listed under the drug column, the first column in this chart, or in this table, and we selected on that, and out of the whole data set, there was 1,168 individuals that had alprazolam in their system. 1,143 individuals had alprazolam in their system with other drugs or in a combination with other drugs. This equals 98% of overdose deaths have alprazolam in their system in combination. And so when you look at those combinations, because alprazolam is the base, the first drug combination, when you run the frequency after alprazolam as the base, is oxycodone. And you had 466 individuals with this alprazolam and oxycodone in the system. The second most frequent combination is alprazolam and methadone, where we had 308 individuals that overdosed with these two drugs in combination in their system. And then the third largest combination was alprazolam and hydrocodone with 304 observations. This is pretty interesting because, like we said before, alprazolam is a lot of times associated with other opiate drug use, whether it's heroin or prescription opiate drug use. And this kind of highlights this relationship to us, and because what we find out in the field is that alprazolam is a potentiator. It actually acts as it's a drug that people that abuse opiates can take to intensify and elongate their high. It's in smaller doses. It's easy for individuals to control, so they feel safer just taking an extra alprazolam to get a little bit extra punch on their opiate drug, and they don't have to worry about possibly overdosing by taking a second oxycodone or a hit of heroin. So it's pretty interesting. And so when you have 98% of alprazolam use in combination, and the three most commonly used drugs with alprazolam are all opiates, and those opiates actually represent 94% of alprazolam use in combination, it really does show us a strong combination or strong connection between alprazolam and opiate prescription drug use. And it doesn't show for sure, but it does give us some good, strong evidence that alprazolam, or quantified evidence that alprazolam is this potentiator people talk about.
And this is Stephanie. We have a question from someone. Wouldn't it be better to simplify the number of drugs to drug categories, such as opiates, benzodiazepine, and meth, et cetera? So that is one approach, and it would simplify it in terms of the presentation. But one of the things that we were trying to get at, and that in particular in a presentation yesterday to the Prescription Drug Abuse Collaborative is useful, is this level of granularity in keeping the drugs separate. Because in terms of thinking about policy recommendations down the line and discussions to have both with treatment providers and also medical professionals and coroners and medical examiners, is what are the implications of this, and is there specific training or information that needs to be provided to patients, to pharmacists, to doctors that targets this specific combination of drugs so that they have, they can look out for that. And One of the other data sources we looked at is the prescription drug monitoring program, and sure enough, alprazolam, hydrocodone, methadone, and oxy are the top prescription drugs in the state. They're the drugs that have the most prescriptions issued for them. And when you see that they're the drugs that are most often found in combination in overdose deaths, well, that leads us to believe that there needs to be a not insignificant amount of education and potentially public awareness or PSA, some sort of outreach to patients in particular about the dangers of combining these three drugs in particular.
Thanks, Stefanie. And another thing, and alprazolam is one of the potentiators, and I just wanted to also say that just underneath cocaine, diphenhydramine, that's Benadryl, that's also a potentiator that a lot of opiate, or a lot of people that have used opiates take to intensify their high. So then you can see that here, especially with the percent combo column, it's very high, 91% of it, of the overdose deaths are used in combination. So that's pretty high compared to some of the others where it's like 86% used in combination. And then when you look at illicit drugs, it's kind of interesting that they're fairly, like, under half of the overdose deaths are attributed or have multiple drugs in their system. So thought that was kind of interesting. So the third and last data set we're going to cover today is the treatment episode data set. This data is pretty extensive data set, and it was at the individual level, and each person was given a unique identifier. So this allowed us to analyze multiple treatment episodes for an individual. But the problem was that each individual was added separately, so they had multiple rows or separate cases instead of each treatment episode being recorded in a separate variable or a separate column. So we solved this problem by restructuring the data set from cases to variables. And this is the syntax here. One of the important aspects of this syntax is sorting your data before you run the cases to variable syntax. And basically, when you sort these cases, you're sorting it by the same criteria that you are identifying the different cases to be combined together. So here you can see sort by cases, and you list the variables, include a space between them. And these will be close to the ID variables. And then you have the case to variables command, and then you have these different subcommands. And I kind of put the definite or their what they're used for below the syntax here. There are more subcommands that you can use for this syntax, but I put the most frequently used, I think, for our office here, and actually saved it in a frequently used syntax file so that other individuals can use it with a pretty hefty explanation. So if I ever happen to leave, folks that come in can use this syntax and have an idea of what it is. So the ID is a list of variables that identifies the different rows or different cases that will be added together. Index command, a subcommand, names the variables in the original data set that should be used to create the new columns. All right, so those are basically the ones that will vary. Fixed command names the variables that should be copied from the original data set, or they're not varying. There's an auto fix that just kind of looks at all the variables for each case and sees if they vary between the cases. And if they do, they create or they combine those cases, and if they don't, they just keep it the same. You can designate what variables to drop, and what I found also useful was the count subcommand, where you can count how many cases that were combined together. So in this instance, during this time period, if the count said 9, this individual went to treatment 9 different times during that time period. What resulted after we basically, I like to say, went from long to short on the data set or cases of variable, we were able to kind of look at multiple treatment episodes for different drugs. And kind of using the same technique with the overdose deaths, the combination of use, we selected the data based on drug, and it's only one variable on this one because it was primary treatment episodes. The primary drug for treatment is what we focused on. And so as you can see there in treatment 1, 100% of these total individuals, there's 186, their first treatment was for heroin. And what we wanted to find is if individuals were moving to prescription-type opiates and stuff like that. And what we're finding is that some folks are. About 10% of the folks on the second treatment episode actually did move to prescription opiates, which include these opiates and synthetics. But you kind of see this trail off after the second treatment episode, which is kind of unique. In other illicit drugs, people came in for a lot more treatment episodes, but with the opiates, they're very small. And the second treatment for heroin, 63% of the folks' second treatment was for heroin again, which is pretty low. Other illicit drugs are about 75, or other drugs like cocaine and methamphetamine, about 75% to 80% of the individuals on their second treatment were being treated for the same drug. So we found that kind of interesting. We also wanted to look to see if people on prescription drugs were switching to opiate or opiate prescription drugs. And here you see in treatment 1, 100% of the folks, and it happened to be 951 people when we selected on synthetics or opiates and synthetics. And you go to the treatment 2, and only 60% of the people on their second treatment are being treated for opiates and synthetics. And we are seeing about a 4% jump to heroin, which I thought was kind of interesting. And then, of course, we can go on to the 3rd, 4th, 5th, and 6th treatments. And basically, through this data set, that was the highest number of treatments for one individual was 6, even though some people self-reported up to, I think, 11 or 12, but they must not have been through publicly supported treatment facilities. So, you know, it was very useful to kind of take the time to restructure this data set, control for these different drugs, and look at these multiple treatments. Even though they're kind of a small portion of the overall treatment, I think only 12% of the treatment episodes were actually, or of the individuals during this time period had multiple treatments. So it's kind of a low number, but it was interesting to see how they reacted over multiple treatments. So in conclusion, and then we can start our conversation or answer some more questions, but you know, especially, you know, just getting done with grad school and taking a bunch of econometrics classes, we're always looking at these data sets so we can do a causal analysis somewhere, and that's great and fine, but it's not what we have all the time to deal with, and it's not always the information, or it's not always the data we have available to make policy decisions or even administrative decisions on an even smaller level. So going after these data sets is a lot of work, but it can pull some important information and kind of prepare you either, you know, for changes or anticipate future needs. And we found recently our analysis of prescription drugs and using all these different data sets really put a spotlight on a lot of different sectors, like what Stefanie said earlier, and how prescription drugs impacted all those different pictures or all those sectors, and really help paint a good picture of prescription drug use and abuse. So I guess our word here, or our theme here today is don't overlook the administrative data. Sometimes it's dirty, needs a lot of work. It's not going to get you that causal relationship all the time, but it can give you some really good insight on the issue at hand. That's all I got for you.
All right, sounds good. So thank you both very much, Sam and Stefanie, for your presentation. We're going to go ahead and get into the Q&A session here in just a moment. If people have questions, they can go ahead and send those through the chat to the host and presenter, and I'll go ahead and ask those when we get around to it. One thing I did want to mention really quickly that might be relevant for some people here is that JRSA is offering a pre-conference seminar called Turning Administrative Records into Research Data at the National Forum on Criminal Justice in Atlanta in August. It's going to be on Sunday, August 2nd. I believe that's a pre-conference seminar. So if this is the type of thing that's interesting to people, that might be something that you're going to want to check out. We'll go ahead and get into some of the questions here. First, I have a question is, when are you guys going to be coming up to Ohio to go ahead and collect this data in our state?
We're laughing pretty hard. After
Sam.
I know it is.
That depends on how much contract money you got to throw our way.
All right.
Well, we're laughing because it was quite a process to collect the overdose data. In particular because DeKalb County actually, it's a metro county on the east side of Atlanta. Part of Atlanta is in DeKalb County, and but they did not collect overdose data electronically since what, 2000, prior to 2013? I can't remember now.
Yeah, 2013 they were converting the records over.
Yeah, so a lot of this was them going into a file room, looking at the files for that year, writing it down on a piece of paper, scanning it into a PDF file, and sending it our way. And so we actually put it into electronic format for them so that they could upload it into their new system so that we could have that information going forward and for other researchers as well. So it did take a lot. Maybe Stefanie, I just had to clean the data from PDF to an Excel sheet, but Stefanie actually had to collect it.
So, and I guess to get to your point, Alan, you know, ironically enough, the way that we ended up getting our hands on the overdose data is because we actually built relationships with the medical examiners in service of collecting arrest-related deaths. Our methodology for collecting arrest-related deaths was identifying the cases via the medical examiner's office, either the GBI or one of the medical examiner's metro area offices, and then reaching out to the law enforcement agencies. So we established a relationship with the MEOs for that purpose. And then when we started to talk about the state drug enforcement strategy and the data sets we wanted to tackle and everything else, we asked the medical examiners, do you all have overdose sets, or who collects that information? We want to know. And of course it was them. So, one of the things that Sam mentioned at the beginning of the presentation is that it doesn't, the data set that we have doesn't include all of the data out of the county coroner's offices. We recently had a conversation with the Department of Public Health using this same information in service of another project that we're working on with them, looking at, I don't know if anybody from Indiana is on the phone, but if you are, you know, one of the things that came to my attention through a friend of mine at the CDC was the issue in rural Indiana around the spread of HIV via injection drug use. And of course, you know, now I'm like eyeball deep in drug issues, and I thought to myself, my goodness, I wonder if something like this could happen in rural Georgia. And what is it that we could do? How do we figure out whether or not this is going to be an issue in rural Georgia? So she and I started talking. She put me in touch with some folks at the Department of Public Health. And then, you know, I was telling her about the different data sources that we were using, and we looked at the TEDS data to see what the prevalence of injection drug use in a number of different of these data sets, to look at injection drug use and maybe find some hot spots that then our DPH folks can look at their HIV surveillance data to see whether or not anything is bubbling to the surface. So all of that is to say that it's all about relationships, unfortunately, about how we ended up coming up with these data and having access to them.
Excellent. Yeah, and it sounds like you made a very important point there. I mean, just briefly from personal experiences, we've done the same type of thing here in Ohio, having to go to coroner's offices and making contact within the Department of Health, and really just trying to pull from a variety of sources. That really does seemed like the best way to make some headway. Really quick, folks, we're going to continue answering your questions here in just a moment. We'd like to go ahead and ask you to please stick around. We're going to open up a poll here, and we'd appreciate your participation and feedback in that. Other questions that we have, I think you mentioned this at the top, but I just wanted to clarify. What are you planning on doing with the data set? Are you planning on submitting it to the ICPSR archive? Are you going to make it available for other researchers? What are your plans for that?
You know, to be honest, we hadn't really thought about that. And I think to a certain extent, I'd have to talk to our program manager over at BJS, and if we wanted to make it available via ICSPR or something like that, I think we'd probably have to talk to the partners who gave us the data, just to make sure that they would be okay with it. I think it would be, you know, a great idea to share. We've done so much work to get, and I say we, Sam, and his predecessor, Ren, have done so much work to get these data sets to be quite beautiful, to be honest, that I would hate to see us just keep them and not, you know, share them with others, but I also wouldn't want to damage any of the relationships that we have by releasing it without, and having other researchers use it without getting clearance from the folks who gave us the data. So I'd have to kind of go back and talk to our partners. We hadn't really thought about that. I did see a comment from Cindy Durrett about the use of the crime lab data. And Sam didn't present on the crime lab data, but that is another. We're using the National Forensic Laboratory Information System data out of our Georgia Bureau of Investigation, and Sam is actively working on trying to clean that up. And holy Jesus. That is, I think, the biggest bear of all of the bears that we've worked with. We've got 10 years worth of data. It's 400,000 cases. The drugs are all in a text field, and they're all non-standardized, and Sam has been working in the, we use SPSS text analytics to analyze text software, so he's been using text analytics to try to create categories, apropos of the earlier comment about creating categories for the drugs. So he's been using text analytics in combination, looking at our Georgia Controlled Substances Act to see what exactly all of these different, because a lot of them are basically molecular, like, names, 1-dihydroxide, whatever. So, so he's been working on that, and it's, so the person who made that comment, if you have any categories or ways of cleaning those up and you want to share those with us, that would be amazing, because text analytics only imports 65,000 cases at a time, and we've got 400 cases to go through. So there's that.
And the other trouble with that too is all the synthetic cannabis that they're finding now, and it's not listed in the Controlled Substance Act. You know, and so it's the molecular compound. It's not like a name like spice or something, you know, it's the actual compound, so it's really hard to categorize those until actually found a Norwegian Wikipedia page or something that had some of these names in there. So it's been a process.
Absolutely, and well, thanks for bringing that point up. And I don't know if you just saw in the Q&A box there, but Cindy said we feel your pain, so maybe you folks can all get together and sort of figure out the best approaches for dealing with that. I want to remind people Q&A is still going on. The poll is still open here. One of the questions that we had for you guys is that, do you know the approximate percentage of people that died from each number of drug? So that is there an overdose from one drug, from two drug, three drugs, et cetera?
So you're asking in combination, like the percentage of people that died in combination drug use?
Yeah, that's true.
Yeah, we don't know the number of drugs right now offhand, but we do know that about 82% of the overdoses were in combination. So that means 2 or more drugs. Okay,
excellent. A couple other questions that we have for you guys here. So you mentioned in at least one of the data sets, I think it was the SAMHSA treatment data, that there's personal identifiers. Were personal identifiers stripped out of all the data that you guys received? Was that something that you guys had to do on your end? How did you kind of handle that situation?
With the TEDS data, it was a code. So that one was provided with the data set.
And that wasn't like an SSN or anything like that. It was just a TEDS unique identifier, but it wasn't, there was no person's name or anything like that. I think we've got birth date or age and race. I can't remember.
Yeah, we got all of that, and county of residence as well.
But there's no address. There's no, I mean, there's not that much personally identifiable information in that data set. So that was stripped for us. Corrections sent us stripped data, right? They only sent us like their offender tracking number. That was a unique identifier in the data set, but there wasn't really any personally identifiable information to a prisoner. And then I don't remember about overdose deaths if that included names. That might have been the only data set?
Yeah, it did include names. Well, I just remember typing them all in for it to tell me. Yeah, it did. So
we would strip, we'd strip those ourselves. And all of the data are recorded in the aggregate, so we don't, we don't. But typically when we ask for data, when we ask for administrative data, mostly because we're not doing any matching across data sets where we would need that kind of information to try to match records. They're all just, the data sets are taken kind of separately. We always ask for de-identified data and trying to mask as much of the identifiers as possible. Rather than asking for zip code or something, we ask for county of residence, getting kind of a higher level so we don't get caught in that mishigas.
Yeah, no, absolutely, and that seems like a good approach, and it probably makes things easier for you guys, and that I would imagine that people would be more likely to want to share data with you if it was de-identified. I think that would probably make people more comfortable about sharing their data. At least that's sort of what I've come across in my experiences. We have another question here for you guys. How difficult was it to get the data from all these different sources?
Difficult in terms of transmission, we just got them by email. Like I was mentioning earlier, the more difficult part was building the relationships to begin with to get people to trust us to send us their information. NFLIS, the National Forensic Laboratory Information System data, actually, John Spear, who did our multi-jurisdictional drug task force impact evaluation, and he works a lot with the Georgia Bureau of Investigations, Applied Research Services, he's the co-president of it. And actually, Tammy Meredith, the conference workshop, the pre-conference workshop that Alan was talking about at the beginning about the use of administrative records, Tammy is teaching that, and I'll be in there with her kind of moderating the workshop. They use our computerized criminal history database as almost as a research database themselves. They do a lot of work for the state in a lot of different capacities, and they use that database quite extensively. And John had asked our GBI crime lab director for the NFLIS data to do the multi-jurisdictional drug task force impact evaluation, because we're the ones managing that contract with ARS. We had a copy of the data. He sent it through us, CJCC, we requested it. So I had that, and I have a relationship with Dr. Heron from working with him on other projects and Coverdale and stuff like that. And the woman who is the medical examiner, who runs the medical examiner database, Julie Gardner, we have the relationship with her from arrest-related deaths. I would say those relationships took about a year to solidify and kind of get together. But now that we have them, it's as simple as sending an email to Dr. Heron and say, Dr. Heron, can I get this year's worth of NFLIS? And it'll take them a while because it's obviously a lot of data to generate, but then he'll just send it right over. It also helps, what we've started to do too is we will send, if we send a data request in particular to our Department of Corrections, because Corrections is a crazy animal, their database is insane, we'll send them a file that has like an Excel file with headers to say, look, we're looking for these types of columns. It's not going to necessarily match the headers in Scribe, but it'll give them an idea of, oh, okay, so they want the data in this structure, and generally speaking, these variables. And that helps to kind of cut down on some of the back and forth and get us the information we're really looking for.
Sounds good, and I think you just sort of touched on one of the themes that you've mentioned across a number of questions in the presentation, right? This idea of cultivating relationships with people, and while it might sort of be a slow process at first, it really does sound like you guys are reaping the benefits of that here down the road. So, you know, hopefully that's something people can keep in mind. One question related to GIS here. Have you guys considered analyzing the data using GIS to identify, you know, hotspots or concentrations of drug use or specific drugs or anything like that?
Yeah, we have, and it's been a pretty useful tool, and so we didn't put a lot of that in here today, but we also like to inlay the roads on the maps so we can not only see with the hotspots with the counties over time or the changes in, you know, overdose deaths or arrests over time, but also see if there's any link between, like, policies of the highway patrol or the you know, of the multi-jurisdictional drug task force, like targeting a certain area, and see if, you know, if we're seeing higher arrests there. Like in our example is the highway. So yeah, it's a great tool, and we hope to be learning Python soon so that we can do more.
Excellent. Okay. Well, it sounds like yeah, that's a useful approach. One more question that we have here is, it says in New Jersey, we believe the prescription drug epidemic has led to a heroin epidemic. So, for example, you know, RX pills become expensive, people switched or they were enticed to switch to heroin, which sells for, you know, $3 to $5 a bag compared to $25 a pill. Just sort of anecdotally, and actually sort of based on some of the data we have here in Ohio, we've seen the same trend. People switching away from some of the opiate pills after we, you know, passed legislation to shut down pill mills here. People sort of moving on to heroin. So is there any indication of that process in your data? Are you seeing a switch from people moving from prescription drugs to things like heroin?
I'm not sure if we're able to say that there is a switch going on between or from prescriptions to heroin, but we can say that heroin use, or at least overdose deaths, have increased by about 700% here in Georgia.
And another thing, so well, I have a question back to you all. What data sets are you looking at to make those determinations about switchovers? Because that's something that Sam and I have been talking about. How do you? It's an illicit market, right? So, and it's happening kind of real time. And so, unless that's where is that captured? I mean, we saw what we presented on the treatment episodes. So we know that moving from heroin, it's actually more likely that a person goes from heroin to opiates based on the treatment data, right? Treatment episode 2, 10% going in for opiates, whereas if you look at the opiates, it's only like 4% going in for heroin. So it looks like, at least from the treatment data about people involved in the criminal justice system, it's actually, so those treatment data are, the referring source is the criminal justice system. So at least for that population of persons seeking treatment, it almost looks like the opposite is happening. You're going in, treatment episode 1 is heroin, treatment episode 2, there's a 10% chance it's opiates, or 10% of these people are going in for opiates. So whereas if you're going in treatment episode 1 for opiates, maybe 4% of them, if they go back for treatment 2, is heroin. So I'm interested to hear what data sources you're using. One of the things that we started doing a couple of, as of a calendar year ago, is collecting street values for drugs from the multi-jurisdictional drug task forces. If they conduct undercover buys, we ask them what type of drugs they buy and what the street value they're seeing in their area is. Until recently, GBI issues these like standardized drug values, and that's what they've been using, but we actually found some not insignificant discrepancies between a GBI standardized drug value and what's actually being going on in the street. So hopefully with a little bit more data collection, we'll be able to see, like, is there a trend, is the value of heroin increasing relative to opiates? Is the value of opiates increasing on the street? Our prescription drug monitoring program is remarkably weak in terms of the access that law enforcement has to the PDMP, the access that practitioners have. The Georgia law is the strictest in terms of the ability, even for medical doctors, to share information about patients in the same practice. You can't print stuff off of the PDMP and put it in a patient's file, for instance. And the record, every single day, a year's worth of records about particular patients are sealed or hidden or archived or whatever. So a doctor can't see more than a year's worth of a patient's prescribing history. And there's a lag for the entry of data. I mean, there's a lot of problems with our PDMP. So, you know, it remains to be seen whether or not that's really going to have an impact on the opiate issue. But anyway, if you could tell me which data you're looking at, I'd be incredibly interested about that.
Okay, so Stefanie's mixing things up, and she's got a question here for the audience. So again, just to reiterate, right, what data are folks looking at? I know this is only supposed to go one way, Stefanie. What data are people looking at to see a switch from prescription opiates maybe to heroin? I believe the individual that asked that was from New Jersey, so if you want to chime back in, go ahead and get in touch with Jason, and I can go ahead and ask that. At least from our perspective here in Ohio, we've seen it across multiple different data sets. So our NIBRS data here in Ohio has shown big-time increase in heroin arrests for possession and trafficking, slight decrease in pills over that time. Same type of thing from the multi-jurisdictional task forces. The coroner data from the Department of Health here has shown greater increase of heroin-related deaths and a decrease in the prescription pill-related deaths. And what was the other source? Oh, the treatment data that we have here in Ohio also sort of shown that trend. So we at least have had some nice convergence across multiple data sources, but we think that's mostly because of some legislation that was passed here. So I don't know if that might cause results to vary from other states. We have another question here for you guys. Did you combine multiple years into one large analysis? If you split the data out by year, does that change anything? Do you see any trends maybe emerging over time, for example?
Yeah, we do. I mean, yeah, we looked at it at multiple, like a cross-sectional analysis over using multi-year, but also we do look at it year by year. Yeah, I mean, some of the interesting trends that we are seeing are the intensity of opiate use in the northern part of Georgia, like in the kind of the mountainous area. We're seeing methamphetamine kind of come up there again too over time. We're seeing a huge increase in heroin overdose deaths over time. I think it went, numbers just off the top of my head, I think it went from 9 to like 59 over a 4-year period, and so that was pretty big. So yeah, we are trying to look at this by year too. So you know, I think that's one of the useful parts of using this administrative data, looking at it by year, so that we can kind of prepare for things in the future, and particularly with this heroin increase that's going on as well.
And the thing that's tricky for us too, in terms of, you know, presenting the results and talking about the prescription drug to heroin issue, is the numbers. So yes, the percentage change is huge. We're talking about like a 900% increase, whatever, from 9 to 59 cases on the overdose, and that's statewide. So again, context, statewide. We're a 9 million person state with 159 counties, and we went from 9 deaths to 59. Whereas with opiate-related deaths, we're still talking about thousands. Our lines, so one of the analysis that Sam did was also looking at, you know, in some states, the line between opiate-related deaths and motor vehicle crashes have crossed, and now opiate deaths are overtaking motor vehicle crashes. Sam did that analysis, and in Georgia, that's not quite the case yet, but they are looking like they're starting to converge a little bit. So, you know, in the arrest data, I don't know that we saw, Alan, we were very jealous. We're not a NIBRS state. And for everybody who's a NIBRS state, we're very jealous. We are a UCR state. And we looked at the UCR data, and so the problem, if you are a UCR state, UCR Part 2 data, opiates and narcotics can be in any of a number of arrest categories. So it's really hard to tease out what is a heroin arrest. The only way we would do that is if we got the computerized criminal history data, which we didn't go after, mostly because of some of the difficulty in the logistics in transferring the file and obtaining the file and all that stuff. So we would just stuck with UCR data. And that's the only administrative data set that we haven't really kind of tried to get our grubby paws on. But it didn't really seem to be an issue, at least in terms of, so if you're thinking about like the end of the line in the justice system and the corrections data, did you see, Sam, I can't remember if we saw, related to heroin?
Oh, heroin's a very small part of the correctional facility. I think in our original conversation with our meth conversation with the National Office of ONDCP, they wanted to kind of put it in perspective, and meth, over time what we're seeing is meth is becoming a really big issue again, and the numbers are just so much larger than heroin. I think they're putting a lot of focus on methamphetamine again. They're kind of asking a lot of the states if they saw the same thing, and we are too. So I think like for our analysis over the years, I think every sector that we looked at, arrests, incarcerations, seizures, overdose deaths, and treatments, methamphetamine is all increasing over time.
Okay, interesting, and I think that shows you some of the value of looking at this stuff by ear, right? Like you mentioned, Sam, you can go ahead and sort of get out in front of issues, and again, just sort of in Ohio, we're sort of seeing the same trend with methamphetamine. Stefanie, one thing I want to mention, right, you did say we're a NIBR state here in Ohio, so if you want to come up like I offered, you can feel free to do that, and we'll give you access to our NIBR state, and maybe you can use some of the Southern charm that you both have to get the guy from the health department to call me back about for a while now. Okay. Got a couple more questions here, and folks, thanks for sticking around. If you want to go ahead and complete the poll, if you haven't already, we'd really appreciate it. One question that we have here, did you guys have to sign an MOU or any other agreements with these guys? Did you have to maybe do like an IRB? What sort of maybe paperwork did you have to do in the process of obtaining this data?
We didn't do an IRB, because when I did the application, I asked for the exemption because we're not trying to contribute to generalizable knowledge. It's not research in that respect. It's really policy research trying to contribute to policy recommendations and practical use. So we kind of, I asked for that exemption. We're not asking for personally identifiable information. So from that perspective, the IRB, we didn't do the IRB. With respect to MOUs, we had not done an MOU, but what we did do is this particular project is run through what I call the State Drug Stakeholder Committee. And really it's a group of folks from all different types of state agencies, the Georgia Bureau of Investigations being one of them, but then there's the Peace Officers Association and the chiefs of police, sheriffs, Prosecuting Attorneys Council, somebody from the Department of Corrections, State Board of Pardons and Parole. So a number of different state-level agencies, the Department of Behavioral Health and Developmental Disabilities, from which the TEDS data come. There's somebody from that organization on the stakeholder committee. And what we've done is, as we have developed the research design and started to get findings, we've brought folks together and started to show them what we're seeing and had conversations about, A, are we on the right track? B, this is our next steps for data collections. Are you all on board? And can you help us obtain data? And that's part of the way that we've kind of run the whole thing. So we haven't had an MOU because we've put the committee together to kind of help grease the wheels, if you will, within their agencies, because most of the time we've hit up agencies for their data. I will say the only data source that we didn't kind of go after, and in retrospect, and maybe, phase 2, we'll definitely sit down with our prosecutors. Our Prosecuting Attorneys Council has a database called Tracker, and it's in most of the district attorney's offices in the state, and that has all kinds of case level data about prosecution. And so I think the next phase as we start talking about moving forward, how do we sustain this effort and keep this committee going, because the goal ultimately is to continue to do surveillance and continue to generate policy recommendations and stuff. It will be to get some of that tracker data and use some of that as well, some of that prosecution data. Okay. No MOUs and no IRB.
Well, yeah, I suppose that's one of the advantages, right? I mean, as you sort of mentioned here, is establishing these relationships. You know, people maybe feel a little bit more comfortable sharing their data, and you don't have to go through some of this paperwork that we all love. So, okay, wonderful. We have one more question here, unless anybody else sends something in. What are your future research plans for this data set? It sounds like you've put some great stuff together. What else are you planning on doing with it?
So the main research recommendation that we are going to propose to our stakeholder committee I was talking about is to let us do surveillance, on their behalf and convene them maybe on an annual or biannual basis with findings and recommendations so that, you know, we kind of keep adding to this. I think, you know, to a certain extent, once we present, and at this point, and I'm not kidding, it's 100 pages, a 100-page report. Once we present this to the stakeholder committee, often what happens, particularly when you start talking about descriptive data, is, well, what does this mean and how do you determine this? And the why questions and the how questions are really going to start to come up, and that's when we can say, okay, if you want to answer that, we need X, Y, and Z, and this is how we would go about doing that, so we'd probably have to build out the data sets. The data sets that we have now are really geared toward descriptive analysis and to show people what's happening and how it's happening. If they wanted more, we'd have to have more, but I think this is the beginning of the start of those relationships. So right now we're just in the problem description phase, and then hopefully with our stakeholder committee and with, you know, all of the policymakers, small p, small policy makers sitting in the room, we can kind of come up with some of those deeper, more causal research questions, or causally focused research questions, and then talk about building out the data sets from there. At the very least, what I do want to do is, because we want to start talking about surveillance, is adding to the data set year to year. So now we have the base, we have the framework, you know, we have the baseline data about drug overdose deaths, we have the baseline data from the criminal justice involved folks on TEDS. And if we wanted to, then we could say, okay, well, what about, how do the folks involved in criminal justice compare to the rest of the treatment population? I think that that is a question that is, you know, fruitful for analysis. So we can, you know, ask for TEDS data to supplement that, and then see where it goes from there, really. The possibilities are endless.
Yeah, no, it really sounds like it, and it sounds like, you know, you guys have put together some nice data and done some really good work at the descriptive level, and hopefully, you know, people are going to see that, and you'll be able to have some more opportunities to start, you know, working at some different levels like you've talked about there in terms of surveillance. So I think that looks like, to me, all of the questions, folks. I want to thank our speakers, Stefanie, Lopez-Howard, and Samuel Gonzales, as well as everyone in the audience for joining us today. We hope that you enjoyed today's presentation, and you can look for this webinar to be posted within the next few days on JRSA's website. That's www.jrsa.org. Again, that's www.jrsa.org. Thank you again, folks, for joining us, and have a great afternoon.